So welcome to our presentation on adapting the FASD assessment process to provide best care to those experiencing homelessness. So we want to begin this presentation with performing a land acknowledgement. And so we respectfully acknowledge that the mustard seed is located on the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to Métis Nation of Alberta, Region 3. So there's three of us presenting today, myself. My name is Sam. I'm the Director of Health and Wellness here at the Mustard Seed.
I am Erin Barham, the LPN and FASD Clinic Coordinator.
And my name is Laura Campbell. I am an occupational therapist and the Health and Wellness Manager.
So we're going to cover a few areas today: the history and overview of the FASD clinic, the population that we serve, the clinic process, and challenges with diagnosis. So FASD is fetal alcohol spectrum disorder. It's a diagnostic term that refers to a broad spectrum of presentations and disabilities caused by prenatal alcohol exposure. And that's what we specifically address at our clinic. So overall, our clinic provides significant wraparound services, predominantly allied health supports with occupational therapy, nursing, psychology, and also counseling. That also includes Indigenous counseling specifically for those that we see. We also have advocates who act as system navigators, which is essential for our clients, moving them out of homelessness and addressing the social determinants of health. So our wellness center opened in 2016 in response to the need that we were perceiving within those that we serve at the Mustard Seed, which includes those who experience homelessness currently, whether episodic or chronic, or those who are on the cusp of experiencing homelessness through poverty or other external environmental factors contributing to it. So we provide significant amount of services per year, 55,000 to be approximate. And we find that it's multifactorial, which contributes to our individual's experience of homelessness that we serve. And what we found was there are a significant amount of individuals that we suspected of having FASD. So going into the history of our FASD clinic, recognizing the need that we saw anecdotally within our clients was also supplemented by the fact that the adult FASD clinic, which serves Calgary, was closing down as of 2018. So we started exploring an FASD clinic in 2017, determining that our current services, which included psychological and occupational therapy services, predominantly providing assessments, would actually work quite well streamlining into an FASD clinic. We partner with an organization called CUPS here in the city, which provides primary care support. And so we have a physician who comes in as well. So it worked out quite well for our clinicians to become trained, myself included. I was the occupational therapist at the initiation of this clinic, to become trained in FASD assessment and therefore be able to fill that gap that was going to become present in 2018. The average FASD assessment costs between $5,000 to $6,000, and for adults, there are no subsidies towards it. So we found that it was essential to be able to provide this for free to our clients. For those who are living in homelessness or experiencing poverty, affording this is just out of reach completely. And the diagnosis can often provide additional supports in the community to our clients to ensure that they are not only able to access, say, secured financial supports, but they're also able to access certain wraparound services that can address the complex needs that they have in relation to this diagnosis. So in 2017, we were trained by the Lakeland Center for FASD in 2018, alongside a variety of other community providers. And they specialize in training, and we're an essential resource and continue to be an essential partner and resource in our provision of care. So the clients of the Wellness Center typically reflect those who experience homelessness. So predominantly male, though we do see an increasing number of female clients. 28% of those are Indigenous, and almost 50% are Caucasian who utilize our services. We do provide pediatric care in the clinic. So our youngest client has been 9 years old, and our oldest client has been 89. However, specifically for the FASD clinic, we saw that gap between males and females actually narrow. And so we serve almost a 50-50 percentage of both sexes. In terms of those who utilize our services, we have noted that it is a higher percentage of Indigenous populations who actually utilize our FASD clinic. Our clinic is predominantly adult, primarily adult. And though we will potentially look into pediatric services in the future, we only provide assessments for adults at this time because it is so challenging for them to access in community. So our team, as I touched on before, comprised of individuals and clinicians who were previous to the clinic. So the occupational therapist and the psychologist and the physician support through CUPS. However, we did add on an additional individual, our clinic coordinator, specific to the FASD clinic to ensure that it was appropriately streamlined and that our clients had appropriate access. And Erin will continue to touch on that.
So the FASD clinic has a basic flow to get through the clinic. It starts with a referral, and that comes from physicians, from outside agencies, even self-referrals, but mostly from outside agencies that are around the city that work with the vulnerable population. The next step in the clinic is seeing the clinic coordinator for an intake appointment. And during this time, the clinic coordinator gathers as much information about the client from the client themselves. Some of the information gathered during the intake includes past and present medical history, a contact person in order to confirm alcohol exposure, and the client's background history. When the intake is complete, the clinic coordinator continues looking into the client's history, including past educational records that might account for learning challenges, birth records, and any other relevant information. While the clinic coordinator is working in the background, the client sees the occupational therapist for their associated assessments, and then the client sees the psychologist for their associated assessments. Once the client has completed all the assessments and all the client's background history has been gathered, the client is then scheduled for what we call FASD Clinic Day. This is where the entire FASD clinic team gathers in a roundtable discussion about the results of the client's assessments that they have completed. Also present with us is the physician, as Sam mentioned, from a partnering agency, and they are ultimately responsible for giving an FASD diagnosis or no FASD diagnosis to the client. And finally, once they have been seen on clinic day, they receive follow-up care through our advocates, and they are responsible for helping the client navigate through obtaining resources such as financial assistance, options for housing, or whatever it is that the client's needs are at the time. The advocates, along with the clinic coordinator, work collaboratively with the client's caseworkers from those partnering agencies that we mentioned to ensure that they receive the right resources for them. This is a quick snapshot into some of the information that the FASD clinic coordinator is responsible for collecting. Looking at the client's whole picture will result in an accurate diagnosis for the client. For example, a key piece of information to collect is traumatic brain injuries the client has had in the past. The clinic has discovered that a whopping 95% of clients have reported or have provided proof of a traumatic brain injury occurring at least once in their lifetime. There is a vast array of reasons for this, but the most common in our clinic that's reported by the clients is it's due to physical assaults resulting in concussion. The post-adoption registry is a huge resource for our clinic. They're able to provide child and family service records regardless of whether the client has been adopted or not. Often these will include valuable information in regards to exposure to alcohol in the womb, any assessments that were completed in childhood, and educational records that would otherwise be out of reach if the client was out of school for longer than 10 years. The most valuable information that is gathered for the FASD clinic is prenatal alcohol exposure, or PAE confirmation. This is gathered by speaking directly with the birth mother, a family member, or witness to the bio mother drinking during pregnancy, or another witness, and very rarely through the birth records. All that said, there are real challenges when it comes to gathering some of this information that we need in order to proceed with a diagnosis. Many of our FASD clients are in unstable housing situations and hop from place to place, making them transient and vulnerable. At times, it is impossible to locate or contact our clients. Sometimes they don't have a phone or an email that they can check regularly. Often they are involved in active addictions that interfere with their assessments and appointments. And sometimes we don't hear from clients for months, only to find out that they were incarcerated the whole time. Frequently, they don't have any form of government picture ID, and that ID is required often for gathering some of the government documents that we need. As well, on many occasions, the clients no longer have contact with family members or their family friends who would be able to confirm prenatal alcohol exposure. There's also the fact that our clients some of them are older and their parents have already passed away. Another challenge that we find is that records are routinely destroyed. Educational records are destroyed after 10 years of being out of school. Birth records are shredded at various intervals depending on the city and the province. And so far, our clinic's experience is that all attempts to get birth records from former reservation hospitals have been unsuccessful regardless of the city or province. Among the information that has been collected during the intakes is that we've made note of some commonly reported medical issues that the clients indicate to us. 34% of our clients say that they have asthma. 29% of our clients report arthritis, and interestingly enough, it is actually in all the age groups that we see the clients reporting arthritis and not just our older population. 29% of our clients report an active hepatitis C infection. 22% of our clients say they have been diagnosed with ADHD. 32% of our clients report insomnia, and 12% of our clients report hypertension. Some other statistics that our clinic has gathered is that we have found 83% of our clients report an active or past addiction to alcohol. 88% report an active or past addiction to substance use. 63% of our clients have reported a criminal history, and 85% of all of our clients have reported some vast array of mental health concerns. So in regards to these statistics, these are staggering to us in light of the fact that these are only the clients that we have assessed, given that there are so many vulnerable individuals who have never had the opportunity to be assessed for FASD or other cognitive disorders. As we have just seen, there are many challenges within the vulnerable population, ranging from physical conditions to addictions to lifestyle, all the way to the records being shredded and no longer being available to assist with assessment and diagnosis. Some of the ways that our clinic navigates these challenges include accessing the client's recent medical history via NetCare, which is our online secure medical record network here in Alberta. Any other medical information we need is obtained through fax requests to the hospitals that clients have recently accessed or in the past. We try to obtain the client's birth records wherever possible and working with the birth hospitals to navigate their red tape. It varies depending on the province and the city. As previously mentioned, clients often do not have government-issued identification. Connecting them with our in-house advocates will ensure that they get ID by helping them with the paperwork and the cost and creating a paper trail in case they need to reapply at a later time. If, for example, medical information is sparse and not much of it is available from Netcare, the clinic relies heavily on collateral information from the client themselves, from their caseworkers, from their friends and their family. The more information that we are able to collect, the better the team can understand their unique challenges. We do have an outreach team here at the Mustard Seed that visits encampments, and they are able to keep an eye out and connect with some of those clients who go MIA and disappear for an extended amount of time. In order to be the most productive, we have an active caseload of 15 people who are in various stages of the clinic process. Being on the active caseload means the client is booked regularly for appointments with the occupational therapist and the psychologist to complete the necessary assessments. And finally, the wait list is thoroughly sorted once a year in order to maximize the flow of clients getting in for intake, assessment, and diagnosis in a timely manner. This includes contacting the client or the caseworker up to 3 separate occasions, and if we don't hear back after a set time, usually 2 weeks after the last contact, then the client is removed from the wait list and their referral is closed. However, that doesn't mean it's permanent. It just means that they will have to refill out another referral and then they'll be put back on our wait list. I wanted to go over prenatal alcohol exposure a little bit more in depth. As I previously mentioned, PAE, or prenatal alcohol exposure, is the most important piece of information that the clinic needs in order to give someone a diagnosis of FASD. A suspicion of alcohol exposure in the womb is just not adequate enough to be diagnosed. When speaking with a birth mother around this topic, it is important to be as non-judgmental as possible, understanding that there are various reasons why a mother may have consumed alcohol while pregnant, and the most common reason being that she didn't know that she was pregnant at the time. When the clinic speaks with the biological mother, we explain where we are calling from and how we are assisting their son or daughter to obtain supports and resources, and that it requires some background information from them. We ask open-ended questions like, what can you tell me about your pregnancy with, let's say, Johnny is his name, and what can you tell me about the time that you found out you were pregnant with Johnny? Usually the biomother is happy to talk about their son or daughter and about their life at the time. Once they have answered those questions, we are able to go a little deeper with questions like, is it possible you may have exposed Johnny to alcohol before you knew you were pregnant? And depending on how the biomother is, we can zero in a little more with each question while still maintaining a non-judgmental approach. Speaking to family members is quite different than speaking to a biological mother. Family members tend to easily hand over the information you are looking for, but this is done with care as well. Most of the time, the family member is able to recount in detail about the biomother, and it's easy to ask targeted questions surrounding their frequency of drinking, as in how many days a week they drank, and approximately how much alcohol was consumed each time while pregnant. You may be wondering why we don't just rely on family members to answer these questions and avoid the biological mother altogether. The answer is that first, it is always best practice to get the information directly from the source, that being the biological mother. We look into family members and family friends when the birth mother is not available, whether she has passed or the client has no way to contact their mother. And second, we have to consider what these family members and family friends' relationships are to the client, and if they stand to benefit at all, should the client be diagnosed with FASD and have access to financial resources. Unfortunately, these toxic relationships do exist within the vulnerable population that we serve. When the client has completed all of their occupational therapy assessments and their psychoeducational assessments, the client is then ready for FASD Clinic Day. As mentioned, the FASD Clinic team gathers to discuss the client's results from the assessments and what that means for them. and whether they will be receiving an FASD diagnosis or not. The client joins the team at the end of the discussion, and then the physician goes over the final result. There are 4 possible outcomes for the FASD client on clinic day. They could receive no FASD diagnosis, and this occurs when we could not find enough hits or deficits in the different brain domains to substantiate an FASD diagnosis, even with PAE confirmed. Clients do not receive an FASD diagnosis, they're not left behind. They are still able to receive the wraparound supports that our clinic offers, and I'll touch on those in just a minute. Clients can also receive the diagnosis of an intellectual disability, and the criteria for that is that they must have an IQ in the very low to low range. They must have deficits in their adaptive functioning, which means that they struggle with one or more activities of daily life and independent living that affects multiple areas, including their home, their work, their school, and their community. And then they must have proof of onset of these intellectual and adaptive deficits from childhood, which is why we seek out educational records from childhood whenever we can. Most of our FASD clients who receive an intellectual disability diagnosis are mild to moderate. Clients can receive this diagnosis in conjunction with an FASD diagnosis or as a standalone diagnosis, as long as they meet the criteria mentioned. The other diagnosis that a client can receive is FASD without sentinel facial features. This occurs when we have prenatal alcohol exposure confirmed, and there are enough hits in the brain domains, but they do not have the 3 sentinel facial features associated specifically with fetal alcohol spectrum disorder. Facial features that are present in childhood often don't appear in adulthood. So in our clinic, most of our clients do not have the facial features of FASD. And the final diagnosis a client can receive is FASD with sentinel facial features. The diagnosis comes regardless of whether PAE is confirmed or not. And the reason for this is that the 3 facial features that we are looking for is only associated with exposure to alcohol in the womb. So a biological mother could state that they did not consume alcohol while they're pregnant, and then their son or daughter could present with a whole bunch of deficits, and then their facial measurements show that they were in fact exposed to alcohol in the womb. These 3 facial features are characterized by small eyes, also known as palpebral fissure length, by a thin upper lip, and a smooth philtrum, which is the ridge between your nose and upper lip. So if you look at the examples there, number 3 is considered normal or baseline, and number 4 and 5 are the facial features we're looking for, and those would be considered as abnormal or below the mean. While you can see that numbers 2 and 1 are over exaggerated, and so they would be considered above the mean. Here is an example of a child shown on the left with classic facial features of FASD. She has small eyes, a very thin upper lip, and a very smooth philtrum. Sometimes the bridge of the nose is flat, creating a button-like appearance, like both of these examples. But as you can see on the right, this person appears to have grown into his nose, but he still has the classic facial features associated with FASD. His eyes are smaller, his upper lip is quite thin, and he has a smooth philtrum. These are the 3 consistent facial features that indicate a child was exposed to alcohol in utero. Within our FASD clinic, and these 4 different outcomes a client can have, our numbers show that 68% of our clients receive an FASD diagnosis, while 32% end up with no FASD diagnosis. Only 7% of our clients have an intellectual disability as a standalone diagnosis, while 41% of our clients received both an FASD diagnosis and an intellectual disability diagnosis. So what does this all mean for the client, and how does it benefit them? While receiving a diagnosis of FASD is difficult for some, it is a huge relief for others. We have various reactions to clients being diagnosed, ranging from a simple shrug of indifference to sitting in silence to crying. Every one of our clients handles the news differently, and that leads to the need for wraparound and follow-up care with the client. Each client has recommendations that are unique to their situation. We start by connecting to partnering agencies and connecting the client with our advocates. The advocates can assist with the client finding a counselor as they process and discover what an FASD diagnosis means to them. And in addition to that, we have an in-house Indigenous counselor that specializes in the cultural practices and customs for healing in our Indigenous population. The advocates help navigate the system to obtain financial assistance. It's called something different in every province, but here it's known as Assured Income for the Severely Handicapped, or AISH. Clients who receive a diagnosis of FASD are automatically approved for funding. This is huge for the vulnerable and homeless population because it opens doors not only for housing and getting off the streets and out of the shelters, but also into decent space that is safe and comfortable, and often sometimes the first time that they're experiencing something like this. If the client has an IQ of 73 or below, they are also eligible for further practical supports. Here in Alberta, it's called Persons with Developmental Disabilities, or PDD. And they can assist clients with goal setting, connecting them to community resources and transporting them through those to and from those community resources, and even help with resume writing, employment planning, if they're still able and willing to work. And finally, behind the scenes, the clinic coordinator takes the information gathered throughout the client's time in the FASD clinic and writes an FASD medical summary report in collaboration with the other clinicians in the clinic. This report includes the background information, the medical history that was collected, and the assessments completed by the occupational therapist and the registered psychologist. The FASD medical summary report is uploaded to the client's electronic medical record in our system, as well as sent to the family doctor, who uploads it to become part of their permanent medical record. A copy is given to the client themselves, as this is their information and it is for them. A copy is also provided to the agencies that they're connected to in order to maintain continuity of care. The FASD medical summary report is also what I like to call the golden ticket, in that this report is what is used when applying for the various supports and resources around the city for the client. And it is used to substantiate any educational accommodations if the client decides to return to school for whatever reason.
All right, I am going to go into a bit of the clinical process here at our FASD clinic. We have a number of clinicians that sit on our team here. A physician who does the facial feature measurements. So a client will be booked with a physician for a brief appointment to measure the facial feature measurements, as well as a registered psychologist and an occupational therapy. The client is booked for approximately 3 appointments with occupational therapy and approximately 2 appointments with psychology. These appointments can range from 2 to 3 hours in length, and they consist of cognitive assessment being administered to the client. So as you can imagine, it's quite taxing on the clients. It's important that clinicians are well versed in standardized assessment, as well as the current Canadian guidelines for FASD diagnosis, and also that they are aware of when to use clinical judgment, especially when it comes to beginning and ending assessment. Here we have the brain dysfunction domains. So they're also referred to as central nervous system domains. Aaron referred to the hits that we're looking for when we're doing these standardized assessments. And these are the categories. So each of these categories represents a neurodevelopmental deficit that may or may not be present in a client that has FASD. Because it is a spectrum disorder, there are differences in presentation of all these brain domain dysfunctions, and that's in relation to the timing and exposure of alcohol while the child is in utero. So diagnosis is made based off the presence of impairment in 3 or more of these domains, as well as in conjunction with confirmed PAE and or the presence of facial features, as Aaron touched on. It's These impairment in each of these domains is determined through standardized assessment, otherwise known as direct assessment, which I will go into. And in order to define impairment, the client must score at least 2 standard deviations from the mean, which can also be used as severe and pervasive dysfunction. Some of the most common disabilities include in our clientele here include attention, executive function, memory, academic achievement, language, and adaptive behavior. So I'll go into each of these domains briefly, but when we're looking at motor skills, it's based off the presence of neurological soft signs. This is primarily determined through direct assessment of motor skills, such as balance and hand-eye coordination. Neurophysiology and neuroanatomy is quite difficult to assess. Most clinics, including ours, do not directly assess this because there is a need for a psychiatrist and or a physician involved in measuring of microencephaly, head circumference, or other physical or medical anomalies. Cognition is typically measured by IQ done by our psychologist. Language, including both expressive and receptive language. So expressive being a client's ability to express spoken language, and receptive being the client's ability to understand language being spoken to them. Academic achievement, this includes reading, writing, and mathematics. We assess memory, including many domains, but typical impairments that we see are in working or short-term memory in clients with FASD. Attention, clinicians, there is a high presence of ADHD in clients with FASD, but clinicians do often have a difficulty differentiating between attention disorder and executive function, which I'll go into, as executive function does include impulse control. So when we define executive function, it's essentially the client's ability to plan and problem solve, but it can include impulse control under quick decisions that need to be made. Affect regulation. We do find a very high incidence of depression and anxiety found in patients with FASD. Our psychologist uses the DSM-5 criteria to determine an appropriate disorder, whether it be depression, anxiety, or a mood dysregulation. And this is done and assessed through a clinical interview with our psychologist. Finally, adaptive social skills or social communication is the client's ability to cope within a social environment, and that's assessed through a number of means. So on the screen here, we have a list of clinical assessments that we do. So we call these an assessment battery that's done by a registered psychologist and our occupational therapist. I'll go into each of these and touch on which domains that they assess. The Wechsler Adult Intelligence Scale, this one assesses cognition. Woodcock-Johnson Test of Achievement, it assesses academic achievement. The Brown's Executive Function and Attention Scales, this assesses both attention and executive function. The Weiss Symptom Record assesses cognition. So you will find that a number of these assessments overlap and assess the same domains of brain dysfunction, which is, I'll go into why after this. The Adult ADHD Self-Report Scale Symptom Checklist, this assesses attention. It is only done if ADHD is expected from some previous assessments that are completed. The DSM-5 self-rated level 1 cross-cutting symptom measure. This assesses affect regulation. And our psychologist also assesses affect regulation using the level 2 depression scale, and as well as the clinical interview that's on the screen there. As Erin mentioned, we do a very thorough records check, including educational records, etc. And the archival records interview is used to determine a number of domains, including affect regulation as one of them. Moving into the occupational therapy assessments. This is more my area of expertise, as I am an occupational therapist by trade, but the behavioral assessment of dysexecutive syndrome, this assesses executive function. So it is a standardized assessment that allows us to do so. The Rivermead Behavioral Memory Test assesses memory in a number of different domains, including that short-term working memory, as well as visual memory, verbal memory, spatial memory, a number of domains. So it gives us a good overall picture. Expressive vocabulary test, this assesses expressive language. The Peabody Picture Vocabulary Test, it assesses a receptive language. UCSD, performance-based skills assessment. This one assesses adaptive behavior and essentially the client's ability to cope within their environment. And the adaptive behavior assessment systems also does the same. It assesses adaptive behavior. A couple assessment considerations that really need to be taken into account specifically within the vulnerable population that we serve. I've referred to this direct, indirect assessment. So direct assessment refers to the standardized assessments that are used by regulated professionals. They're called level B and C assessments. So for the most part, direct standardized assessments should be used to assess brain domains whenever possible for the majority of evidence for brain dysfunction. When direct measures are not possible, sometimes it is challenging and assessments are costly, and there are hindrances on that. Indirect methods can be used. So these include informant ratings, clinical interviews, or historical assessment through file review, all of which are systems we use. These can be used in place of direct measures, but it is important to note that multiple methods should be used when using indirect assessment, which explains sort of that overlap that we assess domains in using many different assessment methods. The second consideration is the length and structure of the assessment must accommodate the individual's needs and capacity. It's really important to consider the status of the client and their specific needs in the moment. So using clinical judgment to cater the assessment process to the individual's needs while still maintaining standardization can be very challenging considering the challenges that many of our clients encounter. It's critical that clinicians be on the lookout for cognitive fatigue, as these appointments can be quite long, so that assessment results remain valid. So this often leads to increased appointments or frequent breaks, which our clinic will always accommodate. Literacy is a good example of some of these assessment accommodations that we need to make, because often many of our clients don't possess appropriate literacy skills to perform the assessments appropriately. And in that case, some of the subtasks actually need to be read to the clients directly in order to maintain standardization. And for the most part, this is considered the gold standard based on the individual assessment. Comprehensive assessment in all domains is necessary to determine strengths and weaknesses. So this is an important consideration. As mentioned, we really only need to see 3 hits out of those 10 brain domains in order to determine diagnosis. That's in conjunction with confirmed PAE in the presence of facial features. However, it is important to assess all domains whenever possible so that we can comprehensively get an idea of where the client's strengths and weaknesses lie in order to provide appropriate recommendations for ongoing supports. These include case management, finding appropriate housing, or appropriate educational supports if that's the client's desire. So some of the assessment challenges that we encounter, there are many, but I will touch on a few here. One of the primary ones is differential diagnosis. So we see that there is a unique challenge to assessing adults with FASD, which is why there are a lot of pediatric clinics available, and there is a unique challenge with adults. That is, many of the clients that we encounter have comorbidities that may present as similar deficits that are present in FASD. So we see deficits in many of those domains. The challenge is determining what is the cause of that hit. Is it based on something that has been pervasive, such as FASD from childhood, or is it something like traumatic brain injury, which may have happened later in life? Erin mentioned the statistic, but our clinic has found 95% of clients that have been through our clinic process have experienced a diagnosed traumatic brain injury at some point in their life. We anticipate this number is likely higher based off just self-reporting. However, it is quite a staggering number. So to combat that challenge, the use of collection of educational records and other collateral information is really important in order to determine whether or not this deficit has been present since childhood or whether it's something that was introduced later in life. Our psychologist collects a history and further data, including severity of the TBI, through the clinical interview in order to determine the presence and severity of that TBI that can help contribute to that diagnostic process. And then ultimately the physician and the psychologist use the compiled evidence to determine if the diagnosis has been pervasive since childhood or if the impairment is related to a TBI. This can result in a diagnosis if it is related to a TBI in major or minor neurocognitive disorder due to a traumatic brain injury. This is a DSM-5 diagnosis that sometimes applies to our clients more appropriately than an FASD diagnosis. Some of the other assessment challenges that we encounter at our clinic are determining baseline status. So this is a real challenge, is finding the appropriate time to assess clients. We have to consider the chronic stress, some of the mental health challenges, substance use, as well as limited sleep that many of our clients encounter. And that can really affect a client's baseline cognition. And so we have to combat that challenge, we take a client-centered approach where we really meet the client where they're at. We often take into consideration collateral information. So we meet with caseworkers or people that might know the client on a much deeper level so we can really understand what their baseline status is in order to ensure that that assessment is appropriate and valid. Another challenge that we encounter are barriers to attendance. Erin touched on this one briefly, but homelessness and the psychological factors really affect reliability of clients attending appointments. We often will see clients leave our clinic process for weeks at a time, and it can be very challenging to track them down at times, especially when there's no access to phones or money for transportation. So to combat that, we offer frequent appointment reminders in whatever means we can, whether that be through a caseworker or directly through the client. We offer transportation through picking up the client on a case-by-case basis. And we also offer bus tickets when needed, if that's an appropriate means of transportation for the client. Like I said, we connect with caseworkers quite frequently to ensure that they know when the appointments are and they can schedule them in and potentially get the clients to the appointments on time as well. So it's really about those wraparound supports, understanding what the individual client needs are based on knowing the client through their intake process and helping them in whatever way we can to get them through the process. That's quite lengthy. Moving on to communicating results. This process is primarily done at the clinic day that Erin referred to, when we have the multidisciplinary team sit at a round table and discuss the client's evidence and results. We then take that evidence to the client, and it is really important that we use appropriate language that can be understood by the client in order to facilitate an appropriate conversation. It can be quite devastating to hear some of the deficits that these clients do experience, and so we make sure that both the strengths and challenges are both expressed in this time. Recommendations following the assessment must address the most basic and immediate needs of the client and assist them in accessing required resources. So that's sort of our follow-up process that Erin talked about. But based off those strengths and weaknesses, we provide the most appropriate supports that we can, and we use our advocacy program to help do that. Finally, the implications for diagnosis. There is the potential for FASD to add another layer to the social challenges that these clients experience. They're often already experiencing discrimination due to the intersectionality of poverty, gender, and race. And adding a diagnosis on top of that can create a complication. So there is an ethical challenge involved in this process that we often consider and reflect on. Within a social landscape that doesn't maybe understand the FASD or the implications for this diagnosis. And often due to this lack of education, there is a continuing stigma of FASD that we've witnessed even within the sector that can maybe even hinder a client. As an example, we've experienced a client that had an application into a housing program and unfortunately was denied on the basis of the client being too complex, just because of their diagnosis with FASD. And finally, psychological challenges. It's a small point at the end, but it's a massive one that we really consider on a regular basis. I often reflect on, is a diagnosis going to help or hurt this individual? Erin touched on this a little bit, but some clients can find a massive relief in receiving a diagnosis. They have now somewhere to place where they've experienced all these challenges their entire life, and now they can understand why that is, and it was due to this diagnosis. However, some clients may not have the ability to understand that, or that just might not be their experience. I have a vivid memory of a client asking the entire team after they received a diagnosis if this meant that their mother hated them. And it was quite a jarring experience to see that, because this individual really didn't understand what the implications for this diagnosis were, and didn't understand that in the process it might open up a world of supports. But we often consider these psychological challenges and make sure that we provide wraparound support such as counseling and case management to combat the harm that might be done through this process. Thank you so much for attending our presentation. We appreciate you being here, and we're going to move into a question and answer period now.